So we'll talk about the aging process biologically, psychologically, and socially. My great-grandmother used to say something, once an adult, twice a child, because as we start to age, we use some of those functions that we had, that we've had over time, and we do kind of revert back to sometimes a childlike structure and how we think and just that process. So that's the part of aging. And although none of us when we're younger in our 20s want to age, it is a part of life. We will all do it at one point. And so I'm trying in my 40s to learn to embrace aging because it's a part of life, and God is allowing us to age. And so it's a blessing because some people don't get to age at all. So psychologically, we have to think about our mind and how our mind works and what we're bringing into our daily routine and what we're allowing as it relates to diseases and things that some diseases we can control. So we can definitely control hypertension, that's high blood pressure, cholesterol. We can control those factors because what we put in our mouths, we can control. We can also control stress and anxiety, although I think it's becoming more of a struggle as we progress in the world. But that is something we have to work on, mind, body, and soul, and self-care, because that impacts your memory too. So what you eat can impact your memory, how you think, self-care, lack of, and then engaging with other people. Some people aren't as extrovert as others. They're more introvert. But it is okay sometimes to get out and be around other people. It just helps those and inspires those endorphins to come out to make you happy. So we'll talk a little bit about that. So I thought I'd pull out some scripture here. Put this down here. Deuteronomy 34:7. Moses was 120 years old when he died, yet his eyes were not weak, nor his strength gone. And basically that says that he lived a long time. And some people say, well, what was that in our years? We really don't know what that was in our years, really what the age. We can speculate if he was 80.
Did you see where she asked if everything was okay?
Someone's mic is on.
Are you cold, Katie?
Someone's mic is on.
You can turn off the fan, honey.
Okay. And then we have another verse, Isaiah 46:4. Even to your old age and gray hairs, I am he who will sustain you. I have made you and I will carry you. I will sustain you and I will rescue you. So those are some scriptures about aging, and that aging is okay. It's a part of life. Socially, different countries, as I explained before, looks at aging a little different. The World Health Organization talks about aging as the process of developing and maintaining the functional ability that enables well-being in older age. Whereas in the US, we look at successful aging, avoidance of diseases and disability, being functional physically and cognitively. In Australia, they talk about having a positive. So you can see in countries how it differs. We're talking about being successful, avoiding diseases and disability, being highly physical and cognitive, where Australia focuses on a positive attitude, feeling good about yourself, keeping fit, staying healthy. New Zealand talks again about attitudes and experiences old people have about themselves and how younger generations view the process of aging. So that collaboration between old and young. And then Japan talks about old age is thus understood as a socially valuable part of life. So it's a part of life. So we see how the world, we all see it a little different. So how can you assist in the aging process? There's a big push to age in place. And what does that mean? That means that the goal is as long as you are able to stay in your home and be functioning in your home. So how can you do those things? You've got to plan ahead to do those things. You've got to be able to put some money aside Some people have policies where it pays for assisted living, it can pay for nursing homes and things like that. And so those policies are not health insurance policies. Those policies are for if you had to go outside of your home to reside, you could comfortably live in a place where they would assist you with medications and other things of that sort. So financially, we don't always think about if we live to we're 100, what we're going to do, because truth be told, if you look at your policies, your life insurance policies, they're whole policies. Some of them do have a time frame on it and some don't, but we don't ever think about what if I'm highly functioning, at least able to move around, walk from bedroom to bathroom to kitchen, and I still need to live at home, but I may need some assistance outside of the home, someone to come in to help maybe do dishes, clean my house, things like that. So these policies, and the name of the policies just escaped me. I think it's not life policy, but I'm going to tell you all for aging. It'll come to me in a second, but the policies are basically to help with those costs that won't be covered by insurance. Because at the end of the day, insurance, Medicare does not pay for assisted living. Medicare does not pay for nursing home beds unless you're on a state plan, which is called Medicaid. You have to pay out of pocket, and a lot of people don't know that. So I'm just looking that up. I wanted to tell you all the name. It'll come to me at the end, maybe, hopefully. Anyways, so things that you do that we consider, there's terms called activities of daily living. That's you bathing yourself, dressing yourself, feeding yourself, moving around without falling, things like that. Independent activities of daily living are things that sometimes we see when people are starting to decline more. You can't use a telephone or cell phone like you used to be able to. Someone has to assist you with shopping for groceries or preparing your meals. You're struggling with managing your medication, or you're missing medication, cleaning your home, managing your finances, and even driving. I am telling you, that's a big piece. When I have to tell someone I advise them, I can't take their license, but when I have to tell someone that they can no longer drive, that is, you would not, it's just a big piece of independence for people as they get older. And so we have to think about those things as we are living longer. Are we prepared to live longer? And what does that look like? And then your emergency contacts. Do you have a list of people to contact somewhere where you can get to that list readily? Is it by your nightstand? Do you have a life alert if you're older and you're at risk for falls, you've fallen a few times, or a medical alert button or something to alert a system? Recently, my 87-year-old neighbor last week, and I've been here for 18 years, and so I know my neighbors very well, and they're mostly older than me. She fell and broke her hip, but she had a life alert or a medical button where she could press it and call for help. So just those things we have to do when we're aging in place. So how can the faith community help and assist older people? It's good in your church, and we'll talk a little bit more about this, to have multi-generational groups. So where we bring the young and the old together, in church for activities or in our Sunday school classes and things like that. Elder care ministries at my church, it was called the All Around Gang, but I think they're changing the name. But it's for older adults, and they go and do activities. They participate in activities. Over the Hill Gang is what it was called. Pairing elderly members with deacons or elders, making sure everybody's assigned a deacon or elder in the church that are older, because they will need some assistance as life goes on. And then being mindful of when we stream live, not everybody's tech savvy, and not everyone that's elderly has a family member that can come over and get their YouTube up or that channel up so they can watch TV. So being mindful of that. And then volunteering, having greeters that can help guide those parishioners that may have some issues with memory. we can actually have our older adults that still have most of their cognitive function be greeters. They can assist in the nurseries as rockers. They can be prayer intercessors and decision counselors. What we don't want to do is, because we age, strip those abilities from those parishioners in the church. We want to make sure we keep them as active as long as they can, because they have a lot of more knowledge than a lot of us. So this is the brain. And the brain is where dementia will house in some people. The front of the brain is where we have our impulses, our memory, how we think. Toward the back here is where we have our balance. It's really the brain that holds the part of the brain, the cerebellum, that holds the whole brain together. So if that part of the brain is not functioning, a lot of the other functions will not take place, vision, what have you. This is just another piece that talks about the different things. So in this lobe here, the parietal lobe, you have knowledge of numbers and letters and vision. Same thing back here is the vision. This does everything. It keeps your balance, allows you to walk. The brain stem. People have had strokes before. It might impact this part of the brain. And so they're not breathing for themselves anymore. They can't walk. They have weakness on one side. Temporal lobe also has the memory, and then the frontal lobe does the thinking and problem solving, decision making. So what is confusion? Everyone else would probably say it a little different. If I went down the line and had someone tell me, it would be different, but it's just a lack of understanding, uncertainty, unclear in one's mind about something. So that's what confusion is. Dementia is not a specific disease, but it's rather a term for the impaired ability to remember, to think, or make decisions that interferes with everyday activity. So we talked about the activities of daily living, the basic things you do for yourself: bathe yourself, feed yourself, clothe yourself. And then we talked about the independent things that are not what you do for yourself, but they're part of what you do, but it's not basic on the body. So taking your medication, driving to the store, making sure you have groceries, able to answer the phone. So those are activities that can be impacted if you have some form of dementia. Alzheimer's disease is the most common type, and there's 4 types of dementia. And let me say this, everyone doesn't get dementia because you hear someone say, oh, everybody has dementia. Not everybody has dementia, even at old age. They may have some memory impairment, but not dementia, defined dementia. So Alzheimer's dementia, most common type. The next common type is vascular dementia. And that's dementia, and we'll talk a little bit about that, that is caused by diseases or can be caused by diseases. Lewy body dementia looks like someone with Parkinson's disease. We'll talk about that. And frontal temporal dementia, they're very impulsive. They make rash decisions. They do things that are very bizarre when they have that type of dementia. So this is a healthy brain, and this is someone with severe dementia. So basically the brain is shrinking, and we can see that on a scan, but we can't tell you on a scan if it's Alzheimer's, vascular. Vascular, we can kind of tell you if you've got some damage to the brain that's related to a disease, but there's not a definitive way to say this was definitely Alzheimer's. We take tests and imaging, and what we do is we put it together and come up with a plan, and we give a educated guess based on research and findings that we've done with exams that we have the patients do to test their memory. And we come up with the best guess that we have based on research. So the only way it would be in an autopsy for someone to do an autopsy when someone dies to absolutely say they have Alzheimer's dementia. Now, someone's going to say, well, what about APOE? That is a gene that is really popular right now. And there's a gene out that people say if you have this gene, you are at risk for having Alzheimer's dementia. It has been studied, so people are looking into that, but that doesn't mean you're going to get dementia. And it was named dementia. A lot of the medical terms are named after someone that's a doctor. Again, it's not a part of normal aging. There's no cure, but there are medications you can take that sometimes slow the progression down. And the reason why I say sometimes, some medications work for some, not for others, but there is no cure. There are new medications that are coming out. One has been recently approved. I don't know the name right off, but nevertheless, there are new medications that are coming out. Usually we start to see dementia in people that are in their 60s. That's the first early onset, and then they start to regress thereafter. Dementia can be diagnosed most of the time, I would say, by a neuropsychologist or someone in the geriatric realm or a neurologist. A primary care doctor could do an assessment, but a thorough workup would need to take place by one of those folks that I just named. And those tests can take up to 1 to 2 days and include lab work, CT of the brain or MRI of the brain. Now, let me say, this is my disclaimer. I don't advertise any medication or anything like that, but I will say that there's some research out there about vitamin B12 deficiency, folic acid, and memory loss. So it's always good to ask your doctor about those levels in vitamin D. Those are some of the labs that we do draw when we're looking at dementia. So we talked about age as a risk factor in your 60s, or if you're older, family history. So if someone comes to me and they say, my dad and mom both had dementia, Alzheimer's type, that is one that I would be concerned about and follow that patient a little closer. And then head injury. Anytime you have a head injury, whether it's a stroke or a traumatic brain injury, you're at risk for cognitive impairment or memory loss. So there's different stages with Alzheimer's dementia. There's mild cognitive, not definite. It's not defined as Alzheimer's just yet. And that can linger on for several years. Someone may repeat themselves often or ask questions that has been statements have been made to them before, and they keep coming back asking the same question. That's the short-term memory loss. Then the mild dementia, which is actually diagnosed as dementia, is about 2 years. And that disease starts to spread, and there are plaques that start to take place sometimes, and the brain starts to shrink. And then so those are folks that may have problems with reading, retaining information. Again, that short-term memory loss, not remembering names of people, seeing people and like, I can't think of this person's name. And then moderate dementia starts to go to the front of the brain where we have poor judgment and we're more impulsive. So you may see these folks, they have a little bit more behaviors. They make comments that they would never make before or are very inappropriate. I see that often. And this person never done anything like that. Short attention spans. And then severe dementia, they're usually saying less than 10 words. They're not speaking much. They're usually not up moving around. And then that's the end stage of dementia, Alzheimer's type. So signs and symptoms, memory loss. I tell everyone, if you start having some memory impairment, to go ahead and start doing crossword puzzles. You can do a jigsaw puzzle, start training the brain. Oftentimes we're good at watching TV, but TV doesn't stimulate the brain. The brain is a machine. You have to work it every day. Seek and finds are a good way. If you're going to watch programs, you might want to watch some Jeopardy, Wheel of Fortune, Family Feud, activities where you have to get the brain to churn. And if you're reading a book, that's another great way. Some other signs and symptoms: problem solving, completing tasks, trouble getting, so the vision and actually looking at what you're seeing and your brain able to process it. And so what you're seeing may not be what your brain's processing, because there's some issues with your vision and what your vision is being interpreted by the brain. New problems with words, decreased judgment with drawing. So some people may show some signs of depression. So be mindful of those folks in your church that are more withdrawn, and they are withdrawn probably because they realize they can't remember and they're embarrassed. And someone may say, well, you told me that already. Well, try not to say those words to people that have some memory losses. That's very hurtful, and they'll retreat and never want to come back out or do things with you. And then changes in mood and behavior. These are some of the medications. I won't go over a lot of those, but you have the cholinesterase inhibitors, Aricept. That is a medication that's in all stages of dementia. The cholinesterase inhibitors can be used. A next type of medication is Namenda or Memantine, that can be used for the moderate to severe stages. Prevagen over the counter, it's about $40. It is not FDA approved or regulated. So we can't say as clinicians if it works or not. I hear a lot of my patients come in, but I've been taking Prevagen. I can't tell them to take Prevagen. I can't endorse Prevagen because it's not approved by the FDA. Some safety tips. If you have someone that you are concerned with driving and you're wondering, oh, does this person that I love know where to go, or that my church member, are they getting lost? You can start just looking around their car. If you see a lot of dings or scratches, that is an indication that this person's probably not driving really safely. And you'll have to make a conscious decision what you want to do about that. If it's someone that's in the home with you, it's a very tough conversation to have. So you all know your family members better. If it's someone in the church, just be very mindful that those things, dings, scratches, bumps, wrecks, accidents, they're getting lost. If they're going just from church to home, those are concerning. We always say if you have someone in your family that has dementia and they live in the house with you, consider alert systems. So if you have an alarm system like ADT, there's chirps that can be put on so when the doors open, because people do wander off with dementia because they don't understand where they're going or they can't process that information. In the home, you also want to make sure if you have someone that lives with you that has dementia, evaluate the environment in the home. So make sure the cleaning supplies, it's almost like proofing it if you had a little toddler in your home, making sure the throw rugs are up because they can fall, having good lighting in the hallway at night if they need to get up and get to the bathroom, making sure there's no weapons that are visible in the home, locking medication up, watching the food temperature. Grab bars should be in the bathroom. Non-skid types rugs should be in there also, but no throw rugs in the house because they can trip over that. Making sure you have working fire extinguishers, smoke detectors, carbon monoxide detectors if you have a gas stove or anything gas in your home. Some famous people with Alzheimer's disease, of course, President Ronald Reagan, Charlton Heston from Moses in the 10 Commandments, Rosa Parks, James Stewart, I think he was Miracle on 34th Street, the actor, just some famous people. So it happens to everyone, every class. The next dementia is Lewy body. Those folks present with tremors, shuffling gait. They look more like Parkinson's patients, but they also have memory loss. And so those are those types of patients. I won't go through too much of that, just some signs and symptoms. Sometimes they have nightmares at night. They have visual hallucinations where they see children. So you can't debate with someone who has hallucinations. If they tell you that's what they see, just say, oh, okay. Maybe get a little bit more information, but don't debate with them. They have restless legs, so their legs are moving in the bed or their arms are flaring. That is some signs of Lewy body dementia, and they could suffer from more of depression too. Additionally, they can have incontinence, which means they're urinating on themselves, or sometimes they're having bowel movements. Treatment for that, same treatments, but they also can be on Parkinson's medication. Famous people with Lewy body dementia, everybody knows who Robin Williams was. He was a famous actor. And then Estelle Getty, Sophia on the Golden Girls had Lewy body dementia. Normal pressure hydrocephalus is not a dementia, but it is something that mimics dementia because you can have memory loss, you can have shuffling feet, you can have urinary incontinence. If it's not caught earlier, it can be, if it's caught earlier, it can be treatable. If it's not, then they'll have worsening symptoms. Vascular dementia is the second most common form of dementia. It's the one that's caused by, or can be caused by, uncontrolled high blood pressure, uncontrolled diabetes, stroke, uncontrolled high cholesterol. And so it impacts the vessels in the brain, which in turn are throughout the body, the vessels in the arteries, and it can lead to dementia. And those patients can be a little bit more aggressive, have inappropriate behavior, and also have some memory impairment, but it's not on the trajectory as Alzheimer's disease. And in the vascular dementia, when you have that type of dementia, usually what happens, you get a decline when something else happens. So say you have high blood pressure and you end up with vascular dementia, but you're not controlling your blood pressure, and then you have a further decline or go in the hospital, then your memory is going to worsen over time. Frontal temporal are those folks who are very impulsive. That frontal lobe is gone, so they can't make rational decisions. And they do things like I had a patient that once dumpster dived, didn't know what he was doing. Their speech is very slow and hesitant. They can't find the right words. And there's no cure for the frontal temporal. A lot of the frontal temporal famous people are people who have had some sort of brain injury, such as Muhammad Ali, or some of the NFL players too. And then mixed dementia, you can have one of two or more of the dementia. So usually you see Alzheimer's and vascular together. So I always say caregiver burden, because people that care for people with dementia, it can be a lot if you're the next of kin. So you want to make sure you're having your own self-care. You want to avoid confrontation. So if they say that something occurred, don't debate with them. Just try to reason with them and say, oh, okay, well, we're going to do this. If they say, no, I've already eaten, say, okay, well, and then check back maybe 30 minutes later. But if you just keep saying, you've got to eat this food, it's just going to upset them, because in their mind, they believe they've already ate. You can do some redirecting someone's attention. So if they're going somewhere they're not supposed to be going, say, hey, let's try to go this way. We're going to walk this way. But you have to do everything in a calm manner, because they're going to get frustrated. We have to remember they are still adults and they want to be treated as such. So how can we assist our parishioners in the church? And I've kind of talked about this. In the church, if our congregation is predominantly older individuals, we should look at having a group that focuses on those older individuals. There are you can partner with the Alzheimer's Association to support parishioners and caregivers. Maybe once a quarter have that group come in and talk to those who are caring for family members, because that's a huge burden. People lose a lot of weight caring for their loved ones. Not that they don't want to do it, but it's very stressful. So look at how you can maximize your groups in your church. Again, having those younger parishioners work with those older parishioners, bringing those together, because the older parishioners have a lot of wisdom to still give the younger parishioners. Create an accessible environment. So we are technology heavy in most churches, and that's great, but not everybody's technology advanced, and our older parishioners are not. I read an article that try to keep some of those old hymns in the church. So say you're singing more of the upbeat songs. Every Sunday you should sing one hymn, because music is the last thing that leaves the brain when you have dementia. If you play music for a dementia patient, they're happy, they're singing those words. Those words are in the back of the file cabinet that's old, that new information's not there. And so having them participate in church, such as the hymns, old hymns, that's a good way of getting them involved. And so some of the things that we do in church is new age. We have to have bits and pieces of it. It's still old age, so that they can feel like they're a part of the church still. Know your church members. I think we have to do a better job all over of knowing our church members. So if you know that someone's spouse has dementia and this person is struggling, how can you help them as a fellow parishioner in the church when they're there? If you know someone's going to be acting out, not purposefully, but because they have dementia, they may talk out loud, they may interrupt. How can you all work together in the church to not cause a scene or make a scene for that person, or not escort that person out? What can be some diversional activities in the church that you can set up as a group to better understand and make it a dementia-friendly church? Maybe shortening the services. If the service is too long, a demented patient is going to get frustrated and want to keep getting up. Again, I talked about the familial hymns, minimize distraction. So if there's noise everywhere, that's distracting because they're trying to listen and put 2 and 2 together. And then create a dementia team. And what does that look like? A dementia team.
This is Charlotte Rock. I think one of the things that we can do is to make sure that we have an educated parish group, that people understand what dementia is and what is happening in the aging process. And once you have an educated group of people,
so we definitely want to create a team of volunteers that want to learn about dementia, because you have to be invested in it, because it's hard work. And so you want a group of people that are invested in it, learn about dementia, how to approach people, what to do if they become combative, how to de-escalate. So it's just like, I don't know if you all have it at your all's church, but at my church, we have a medical team that responds if someone's having a medical issue. So the same thing, you'd have a team for patients that have memory impairment, so that everyone knows what to do if this person reacts, because there will come a time in church where someone will have some memory issues, or they're wandering around. Maybe that person that's wandering around, that someone from the team can take them outside of the sanctuary and walk around with them to kind of, because some demented patients like to walk a lot. So you have to be very creative in what you're doing in your church, but you also have to be mindful that they're still parishioners and they still want to participate. So how can you develop the church program to be more inclusive? You also might consider like a respite group just for those, and I kind of talked about that, those who are caregivers, to assist caregivers. There's a lot of burnout, and when people burn out, they may be the only person that's caring for that demented patient. Or we could say that patient that not patient, but that parishioner that has special needs. There may be someone caring for a child that with special needs. So consider having like a group where they have a respite group. At my church, we call it caregivers group, where you have this group that's supporting those persons that are caring for others. And so we kind of hit on at the beginning, end of life. We all know that we're going to leave the earth. We don't know how we're going to leave the earth. But we want to make sure that we are prepared as we age for the end of life. And it's not a situation where someone else has to think on their feet if something were to happen to us. Making sure we have a living will or advance directive. Who do we want in charge if something were to happen to us? Being prepared. I think we always say we have more time, but we never know if we have time. I'm 45 and I have an advance directive, so that if anything were to happen to me, my loved ones wouldn't have to say, make a tough decision. So that's something we have to think of too. And that should be something that we're talking about in the church too, is being very open to death and dying, because it's a process and we all must do it. So now I have some time for questions, if anyone has any questions. And there's no bad questions for me. There's no bad questions. Sometimes people...
This is Carol Sapp.
Okay.
What information do you have in regard to addressing this topic with families who have adults with developmental disabilities, as far as the aging process?
I think that those who have developmental disabilities, my niece is one, she's 13, she's developmentally delayed. I think that we have to be very, again, mindful of that there's something that they're delayed, how we can still have activities wherever we're at, if it's at church, if it's at a family function, how we can incorporate them into those activities so they don't feel isolated. I think oftentimes because people are delayed or developmentally delayed, sometimes they're isolated from events. So having those conversations with family members to say, hey, we really have to be mindful of such and such and make sure that we're including them, and letting them be who they are to their level. I think, and I'm guilty of it. My niece is 13 and I'll go ahead and I'll start working on something, doing something for her. And she's like, I can do this, Auntie. I've got this. So we have to be mindful of that. And we have to allow them to meet their needs based on what they can do. And when they can't do it, then we step in. But we have to include them too, because they're human just like we are. So have those conversations, even if you got to have them on the side to say, hey, let's think of some ways that we can include family member X in some activities that we're doing so that they don't seem left out. Or if there's a family member X that has some behaviors or is disruptive, how can we as a family better serve and intervene when things like that happens that's not disruptive to the whole group of family members?
Cynthia, for question.
Yes.
Could you go back to slide 19, where it's the treatment? I wanted to write down the medications.
Medication. Sure.
Yes, thank you. I wanted to read. I couldn't read it all. Sorry.
That's okay.
And this is Karen Stokes. I wanted to ask you, how did you go about establishing your caregivers team, and how do you get people to volunteer and train them as part of the caregivers team?
So I haven't established at my church. The glory in it is they have teams that have been established. I think that you have to put a call to action to say that we are aging, our aging population is living longer. We want to make sure that they can be in the word and with God and with the rest of us every Sunday that they want to be here. So how can we support them? We're going to form a group and we're going to have members that want to learn more about the aging adult and those who have memory impairment and how we can serve them. It's no different than when we have daycares in the church either. We have to have volunteers for that. So we definitely want to keep our elders in the church as long as we can, because that's something that they've done for years, and most of them enjoy it tremendously. They take value in going to church because that is something that they did as kids. When they were married with their kids, they went to church. And so we want to encourage that. And we want to make sure that we're including them. We are so techie, and I love my church, but we are techie. And this past Sunday, it was funny. I was talking to my mom about a hymn and they sung the hymn, and I knew the hymn because I remembered it as a little child. And we were talking about hymns, my mom and I thought, and all the elders, I was watching, all the older people were standing up and they were clapping. Because sometimes we sang the upbeat songs and they were clapping and super excited because that hymn had so much meaning and power to it. Those were probably songs that they sung when they had hard times or something was going on with their family, and they could go and pull that hymn out. So music is one last thing that leaves when you have memory impairment. So I think it's just inspiring those in your congregation. Even if you start with 2 or 3 and y'all just have some brainstorming, how can we get this and how can we do it where people don't feel burdened? Because that's the thing, everybody's busy. So don't overwhelm them with meetings, but do set a group up and identify and let your parishioners know in the church. We're just going to identify if you have someone in your family that has some memory impairment. We're happy to be there and support when need be. I think we all know those ones that sit in our section that have some issues with memory, but how can you better support them? But the old hymns, making sure that if you have screens in your church, making sure the words are visible and not really small, because not everybody can read that. Or if they have it up on the screen, maybe they need a piece of paper. I know some churches are getting away from having handouts, but making sure that those folks have some papers that they can actually see and be able to read to participate. And if you have a few Bibles, the easier versions, like the the New Life Translation, things like that, bigger words, have those too, just so that's inclusive as you can be. So start off small, get somebody that you trust, 2 or 3 people, and say, hey, I'm thinking that we need this group, just to make sure that our elders in the church feel appreciated and know that we're here to support them.
Thank you.
You're welcome.
I have a question.
Sure.
It's Joy. Hey, I have a question about, there was a situation where, the pastor was suspected of having dementia. And can you talk to me about how a church can handle that? It could be a Sunday school teacher or a pastor or, you know, any of those situations, but a person in leadership. And what would be the best way to handle that? Can you give us some insight on that?
Sure. I think it's challenging when you have someone who is respected and held in high regard, such as a pastor or deacon or elder in the church. You first have to know, is it really true? So you can determine that in 2 or 3 Sundays, if the person keeps repeating themselves or making mistakes that they don't mean to make. And then I don't know about your church, but most church have deacons or trustees where you can have a conversation. It may not be that the pastor that's leading the flock it may be that the pastor that's leading the flock has to step down, but they're still in a pastoral role and someone else comes in. But that's a really hard decision for a church to make, and it can split and divide the church up. But if there's a pastor that's no longer able to serve the parishioners to their full capacity, then it is a conversation that either the deacons and the trustees together need to be aware of. And even if they're aware of it, sometimes it's hard for them to make that decision or that call. But that is something that needs to be discussed, because after a while, that's going to impact the church and the attendance of the church. If you have an older, someone with dementia, I don't even want to say older, someone with memory impairment that's not able to guide the church in the direction it needs to go to serve God. Did that answer your question?
I think, yeah, thank you. Unfortunately, it's too late, but I feel that others could. The church did split, and it's been many years ago. The church did split, and the pastor has gone to Jesus now, but it could happen, you know, and so, and it obviously did happen in this situation. But I have a quick question. I don't mean to, can you talk to gait disorder? Help me understand what you were saying about the gait disorder. Does it simulate dementia, or is it
When
a
I was
part of
talking about the normal pressure, hydrocephalus, and falling and things like that, is that what you're talking about? Or
yeah, if somebody has been diagnosed with a gait disorder, do they also have is that more than, I don't know a lot about it, and so
well, a
does that
gait
also
disorder could
affect
be
their
well, it could be multifactorial. A gait disorder. A gait disorder could be something going on with the lower back, causing the legs and the muscles not to be strong enough to hold them up. It could be that they've had multiple falls, had a fracture before, and they're just not able to ambulate. So a gait disorder. Now, if they have a gait disorder, memory loss, and they're having accidents, then that's something that needs to be investigated. But if it were my family member and they had a gait disorder, I would make sure they're seeing a neurologist to investigate it a little bit further, to see and ask that question, what is causing the gait disorder? And I will say, someone with dementia, as it progresses, they do start to fall more, because the ability, and it just depends on the part of the brain that's impacted. You may not be as steady on your feet if it's a part of the brain that developed in the back where there's coordination and function. So if they've not seen a neurologist and they have a gait disorder, I would definitely recommend that they see a neurologist. Now, if they have a primary care doctor, make sure they've exhausted all their possibilities so that they're not offended, but you can always ask to see a specialist.
So just because they have a gait disorder does not mean they have dementia or Alzheimer's. It's not headed into that. Is that correct?
Well, those don't
Not
correlate
necessarily.
necessarily to dementia. No.
Okay, okay.
But if the person if they're falling often, you want to know why they're falling, because if they continue to fall, they could hit their head, or they could have possibly already have hit their head and have some memory impairment from multiple falls. So that's definitely has to be investigated.
Thank you. I
You're
understand.
welcome. You're welcome. No problem. There's one more thing I did tell you I was going to tell you. I was going to drive me crazy. It's long-term insurance. As you get older, it gets more expensive, but long-term insurance, I used to round in nursing homes and assisted living at one point in my career, and long-term insurance saved a lot of my patients' pocket, because when you have to go in a nursing home, they spend down your money. I'm not going to get into the legality of it, but they spend your money down, and then they use your money to keep you in nursing homes. In the state of Kentucky, in a nice nursing home, a private room can run you $10,000 to $12,000 a month. So I always tell people, if you don't have long-term care insurance and you can afford it, it's worth having. AARP, different places carry it, because if you have to go to assisted living, you have to pay out of pocket. And that's from when you're going from your home to where they're going to maybe issue you your medications or help you get dressed, things like that. Just be mindful of those things, because it's and if you don't have an advance directive or a living will or long-term care insurance, it's wise to speak with an elder law, specifically an elder law, someone who focuses only on elderly law, and make sure you have your affairs in order, especially if you have more than one kid, because if you have 3 or 4, they're not always going to agree on what should happen. I'm telling you, I've seen it a zillion times. So I think it's best for the person to make their own decisions and have it written down, and then it's followed, because the attorney signs it and it will be followed, and there won't be any discord in the family because decisions were not made prior to.
This is Jane Burris.
Yes.
And the younger you are at getting a long-term care insurance policy, the better. Because I got mine when I was around 35, and it's been in place and it's there for life.
Good. I'm glad you have it, because a lot of people don't know about it until it's too late, and it's very expensive. And I'm telling you, if they can nickel and dime you, they'll take all your money. Yeah. Any other questions, comments? So just some key takeaways. If you can, work with your church to make sure you have a group that supports older people as they age successfully. Work on that. Make sure that you have your affairs in order too. Advance directive, who's going to make decisions if you can't make them for yourself? Living will, if you have assets, who's going to get what? Do you want to be resuscitated? Don't you want to be resuscitated? Those things should be made while you're in your right mind, because if you have dementia, you can't make those decisions. You can't sign forms. Or if you're confused, they won't allow that. All right. Well, thank you all. It is 8 o'clock my time. I know it's 7 year olds. Thank you all for participating. I hope that you enjoyed the segment, and I hope that you go back to your churches and advocate for our older people. I love old people. My favorite person was my great grandmother. I had her for 16 years of my life. She was amazing. And she loved church, and so we would go to church often because that's what she liked to do. But I think that there's a place for our elders. I know that we are new age and there's younger people in the church, but we've got to have both groups. And if we could get these groups to combine, our youth would be so much better. If we could get these groups connected with older people, I feel like our youth would be so much better.
What are some ways that you think you can do that? Have your church tried to match a youth with an adult or older adult, and If you
Well,
have,
we do some things like that. We do it usually if we have Men's Day, Women's Day choir. We partner, we get the kids involved and put them in the choir. We have been working on being very mindful of, we do have children's church, but making sure we have church all together. I'm getting the children involved, but I think we still have work to do. And I'm in a progressive church on making sure we bring those youth and those elders together. I think there's a lot of work we could do.
okay, okay, thank you.
Well, it's a struggle because, as you know, it's a different type of youth nowadays, and they're not, to be quite honest, a lot of people aren't bringing their kids to church any longer. Not like it used to be. It was not a decision for me, but a lot of children nowadays, it's a decision. So I think the first thing is getting the parents engaged about making sure their kids come to church.
Mm-hmm. Yeah, because they have choices now.
They do have choices.
You know, we didn't have choices.
No.
Hey, Dr. Usher, this is Barbara. I have to say, getting the parents involved to get them to bring their children to church. Back in January of this year, we started a community connection. And I felt so strong about it because of that very reason. People are not bringing anybody to church, even themselves. And if you can have a connection going on in the community to meet the needs first, and then show that love, Christ's love to them, then you could kind of start bringing them into the meeting at the church. But you got to meet physical needs and things like that. And also along that line, millennials, and specifically millennials, they want to do. They don't want to come sit and listen. So I've taken youth out to help people, like older folks, in their yards and stuff like that. But I think getting them involved is a huge piece.
I agree with you. I agree with you. We have a push coming up in September to invite. And so I've been inviting folks. And even my 13-year-old niece, she said, well, I don't get up early for church. And I said, well, you need to try. So they have this mindset that. Well, thank you all for sharing your evening. Any other questions? Great dialogue. We've got to take care of self first so that we can make sure that we don't leave any assignments for anyone to have to do on their own. And that's a tough decision for a kid to make or grandkids to make. So make the decisions for yourself that you want and that you like to have. But also get busy in the church for the older people.
Do you remember the name of the insurance company?
There are several different types. Most insurance companies have it, but AARP definitely has long-term care insurance.
I think you said MetLife for daily activities. You remember?
No, not MetLife. I don't know, but they may have long-term care insurance, but I know AARP definitely does. And if you you can always call your insurance carrier if you have State Farm, or sometimes State Farm has a little bit more than some of the other places, or Allstate, they may, but AARP definitely has long-term care insurance.
This is Jane Burris. I have Mutual of Omaha.
Okay, that's a good one too.
Excellent.
My mom's is called Continental. It's out of Texas from somewhere. She and my dad started when they were 70. And my dad has passed away and never got to use his, but my mom is using hers. She will be 88, and she's been in assisted living for a year and a half. And I pay the check at the beginning of the month, and at the end of the month or the beginning of the next month, the long-term care sends me, pretty much the full amount. Now, they don't pay anything if you have to go in rehab.
Right.
Don't pay anything. If you for hospitalization or anything like that, but for just the assisted living, and if and when she ever has to go on to the skilled, they pay, portion for that. And she has a a life max, but it's very high.
That's great. That's great that your parents were progressive and went ahead and got that going.
Yep. And theirs was kind of an old policy. They only had to pay for it for 10 years and it was expensive, but they paid for it for 10 years and then they didn't have to pay any more premium after that 10 years. And sadly, my dad died, right after that 10 years, but my mom is using hers and she hasn't had to pay any premiums in 18 years.
That's
Yeah.
a blessing.
And
That's a
I don't
blessing.
take for granted.
Yeah, that's a blessing. All righty. Any other questions?
This is Suzanne Stevens. Just a quick question. I got on here a little bit late and I believe the session has been recorded. Isn't that right, Marilyn?
Yes.
Okay. And so will it be available like on the BNF website or?
It'll be on the BNF's website sometime tomorrow. I put that in the chat for everybody to know that we'll be able to post it tomorrow.
Wonderful. Wonderful. Thank you so much.
All right.
I
well,
did not notice the Eastern Standard Time. 7 o'clock Eastern Time. I didn't notice that, so that's why I was late. I'm just sick about it.
I don't think you were by yourself. I think we had a few other different time zone people coming in. So
Okay.
Well, I
you for
thank
coming
you
in.
all
You got
so
here.
much. I thank you all so much for your time. Let's just go out and do the work of God and be great. Let's help who we can, and let's just be prepared for ourselves too and make our own decisions so no one else has to.
Thank you.
Thank you.
Thank you.
Thank
You all have a
Dr.
wonderful
Usher.
night.
Thank
Thank
you.
you.
Bye-bye.
Thank you very much.
No problem. Bye-bye.
Good night. Thank you.
Good night, everybody.
Good night.
Thank
Good
you.
night,
Good night.
everybody.
Good night. Good night.
Good night.
All right, where's Barbara? How do I get out of this?